अजून चालूच नाही केली. तर तुला व्यवस्थित दिसतं ना सर्व? ठीक आहे. हा सेम अजून चालूच नाही. कसली लिंक? हा युट्यूबची लिंक पाठव. हा हा मला दिसणार नाही ना अजून. हो ठीक पाठव. ठीक आहे. मला दिसतं ना?
A very good evening to all the delegates present here. Firstly, a very sincere apology to all of you for this delay. I, Karishma Singh, would like to welcome you to the Hriday 2024 Conclave. A very warm welcome to all of you from the team Aristo and team CME Foundation India. Aristo is one of the fastest growing Indian pharma company, and having grown consistently year over year, we are proud to say that we have reached a top 10 league by the turnover, and this shows the trust that medical fraternity has bestowed in us. Well, we have the team Bihar here, and Bihar territory has definitely played a very instrumental role in the success of Aristo. And not just that, this moment is even special because we are in Ayodhya. Yes, the Janmabhoomi of Ram Bhagwan, right? And therefore, this makes it even more special to do this in Ayodhya with his blessings. Extending helping hand to our doctors has always been the driving force for Aristo, and therefore we have gathered here with the same objective to enable you with a very insightful session on obesity and CK. So therefore, I would like to take this opportunity to welcome our guest speaker for today's program, Dr. Mrityunjay Kumar Singh. So can we have a big applause for him, please? And I would now like to call upon Himanshu sir to please felicitate the doctor, and then we can move ahead with the session.
थैंक यू वेरी मच। सबसे पहले तो मैं आप लोगों से क्षमा प्रार्थी हूँ कि मैं यहाँ लेट आया। जब आप अयोध्या आते हैं तो राम जन्मभूमि सरयू नदी देखना जरूरी होता है, और उसी के दरमियान लेट हो गया, तो आप सबों से क्षमा प्रार्थी हूँ। मैं गया से आया हूँ, तो विष्णु की धरती से आया हूँ, और आप सबों को मेरा नमन है। तो नाउ कमिंग ऑन टू द टॉपिक इज ओबेसिटी एंड क्रोनिक किडनी डिजीज। तो मैं इसे एक जोक के साथ शुरू करूंगा। एक साइकिल के दुकान पे एक ऐड लगा हुआ था। उस ऐड में ये लिखा हुआ था कि आप हमारे यहाँ से साइकिल खरीदे, ये आपको बढ़ते पेट से बचाएगा और बढ़ते पेट्रोल के दाम से भी बचाएगा। तो ये काफी हद तक सही भी है। तो इसी के साथ मैं अपना टॉक शुरू करता हूँ। ओबेसिटी इज अ कॉम्प्लेक्स मल्टीफैक्टोरियल कंडीशन characterized by excessive accumulation of body fat leading to adverse health effect. It is commonly defined by a body mass index greater than or equal to 30 kg per meter square. But this BMI is true for Asian or Indian? आप लोगों से जवाब चाहिए मुझे। क्या ये BMI एशियन और इंडियन सब पॉपुलेशन के लिए ट्रू है, सही है? क्या होना चाहिए BMI? अब वो तो नॉर्मल BMI हो गया, वो हो गया ओवरवेट हो गया। मोर देन 25 ओबेसिटी में आता है। तो हम लोग के यहाँ जो ओबेसिटी का है, एक्चुअली जो ये WHO है उस क्राइटेरिया को नहीं मानता। WHO का डिफिनेशन यही है कि BMI जो है मोर देन 30 किलोग्राम पर मीटर स्क्वायर होना चाहिए। पर इंडियन जो एक्सपर्ट है, इंडियन सब कॉन्टिनेंट के जो एक्सपर्ट है, उनका ये गाइडलाइन है कि हम लोग के यहाँ जो ओबेसिटी होगा वो 25 किलोग्राम पर मीटर स्क्वायर, क्योंकि हमारे यहाँ सेंट्रल ओबेसिटी ज्यादा होता है, फैट का डिस्ट्रीब्यूशन ज्यादा होता है, तो BMI को हम लोग वो वेस्टर्न कंट्री के हिसाब से नहीं मान सकते। ठीक है, तो हाउ इट इज एसेंशियल टू रिकॉग्नाइज दैट ओबेसिटी एक्सटेंड्स बियॉन्ड mere body weight. It involves metabolic dysregulation, chronic inflammation and various comorbidities. So why we are discussing obesity? Because it is a global health concern and obesity has tripled since 1975. अगर आज के डेट की बात करें तो पूरे वर्ल्ड वाइड 80 करोड़ पीपल ओबेसिटी से ग्रसित है, 80 करोड़। और अगर 2035 की बात करेंगे तो 150 करोड़ लोगों के ओबेसिटी होने का अनुमान है। 1.5 बिलियन पीपल विल सफर फ्रॉम ओबेसिटी बाय द 2035। सो इट इज द इनॉर्मिसिटी। और सबसे बड़ी बात, ये जो हम लोग थर्ड वर्ल्ड कंट्री हैं या जो बोलते हैं कि अभी लो इनकम और मिडिल इनकम कंट्रीज हैं, वहां पे जो ये ओबेसिटी है वो 2035 में 80% ओबेसिटी का वो होगा। तो हम लोग जो हब बनने जा रहे हैं ओबेसिटी का, and it is associated, it has not only it has not spared children as well. Children even below 5 years of age are suffering from obesity, and it is a major risk factor for numerous chronic diseases like stroke, heart disease, type 2 diabetes and other leading causes of death. It has also been associated with musculoskeletal disorders like osteoarthritis and also associated with mental health problems. So the global economic impact of obesity is substantial. Now you can see here that global burden of diseases, when it has been studied by Lancet, what it has found that in 1990s the daily means disease disability adjusted life per year, Delhi is for the high body mass index, it comes around 16. It comes around in the 16th position. But in the next 20 years, it has stepped up in the ladder, and now it has come to the position of 5. So body mass index is a major growing problem worldwide. And how to assess obesity in CKD? We all know BMI we use in our clinical practice. BMI means body mass index, body weight divided by height in meter square. This is what body mass index. But is it the true index? Because if you will see in this picture, with the same height and same weight, the both person will have same body weight, same BMI, but they have different body compositions. So they have different fat. One person has 20% body fat, and one person will have 36% body fat. So BMI is not giving the true picture of obesity. So what else we can do? So we have CT and MRI. for measuring body fat, but it is accurate measure but expensive and not available everywhere. Now the cheaper method is waist circumference, easy and inexpensive measure, and large waist predicts all cause and cardiovascular death. So in one of the studies, they have combined body mass index with this waist size. For waist size, Asian population waist size for female is more than 79 centimeter, and for male it is more than 89 centimeter. And what it will change? It will change the risk. If you see the same overweight person, if his waist size is above the reference level, his risk will high, from increase to high. So if you will combine body mass index with waist circumference, then it will give the true picture. And it is also very inexpensive. So we can do it in our clinical practice as well. Now the question is whether obesity is associated with chronic kidney disease. There are several studies. I am not going to detail it, but they all have shown that obesity is associated with significantly increased risk of microalbuminuria, and they have increased risk of chronic kidney disease, increased risk of progression of CKD, and increased risk of end-stage renal disease. In the certain studies, some data exists to suggest that obesity is a risk factor for progression of primary glomerular disease like IgA nephropathy. Obesity also in part increased risk of ESRD following live kidney donation. Means a person having obesity, if he had donated kidney, then he has increased risk of CKD if he will not take care of his obesity. Now, what are the structural changes occur in obesity? Fatty infiltration of the kidney parenchyma. There will be hyperfiltration. There will be intraglomerular hypertension. There will be mesangial proliferation. There will be glomerulomegaly, which is also told as obesity-related glomerulopathy. And the first condition, it will be converted into focal segmental glomerulosclerosis, which will be secondary form of focal segmental glomerulosclerosis. Here we have to understand that in obesity-associated condition, there will be some nephrotic proteinuria. In some cases, you can get nephrotic proteinuria, but you will never get nephrotic syndrome like picture. So what is the difference between nephrotic syndrome and nephrotic proteinuria? Nephrotic syndrome will have all the conditions like edema, hyperlipidemia, and hyperlipidemia. But in nephrotic proteinuria, it will only proteinuria above 3.5 gram per 24 hours. So you have to divide it into nephrotic syndrome or nephrotic proteinuria, because if there is in an obese patient, if he has suffering from nephrotic syndrome, then you have to treat it with immunosuppressive, not by giving all other drugs. So you have to differentiate whether it is primary glomerulonephritis causing nephrotic syndrome or it is obesity causing glomerulomegaly. It is very important. And obesity is not only causing glomerulopathy, but it is also involving tubular interstitial system. So now the term has changed. It has been called as obesity-related kidney disease. And the typical clinical course is stable or slowly progressive proteinuria renal impairment, but the long-term outcome will put progression to end-stage renal disease in 10 to 33% of patients diagnosed with obesity-related glomerulomegaly. So you have to differentiate it, because primary FSGS there is a rapid progression. In this form of secondary FSGS there is a slow progression, and the treatment is also different. So you have to differentiate between these two conditions. Now coming to the hemodynamic pathway, how the obesity alter the hemodynamic pathway of kidney, because obesity and adipose derived factors will activate the RAS system, will activate this sympathetic nervous system, and it will increase the renal plasma flow, increases the filtration fraction, it increases the tubular salt reabsorption, it increases systemic hypertension, it will alter the tubuloglomerular feedback, it will cause afferent arterial dilatation, and it will cause glomerular filtration. And if you will see this data from the REAN, you can see here that anti-proteinuric effect of ramipril is more in obese proteinuric patient. And so this renal hemodynamic changes is proven by this study also. Now there is an inflammatory effect of obesity, and there are two adipokines which I want to discuss here. One is leptin, and second is adipokine. They both act in reverse direction. So leptin binds to obesity related antigen or obesity related receptor in the glomerulus, in upper glomerulus, tubular glomerulus, TGF and increases mesangial extracellular matrix. It activates sympathetic nervous system and hypothalamus, causes hypertension, and it also increases sodium retention. And adipokines has just reverse action, but in obesity, the leptin will increase and adipokine will decrease. So adiponectin decrease will neglect its all positive effect, and it will have inflammatory effect because of decreased adiponectin. It will increase insulin resistance because adiponectin level is low and leptin level is high, and it also got podocyte dysfunction because adipokines protect podocyte, but due to decreased adipokines, there will be podocyte damage. And this all has been beautifully depicted here, how these pathways involved in the obesity related diseases. Now coming to the factors which predispose obese individual to renal injury. So क्या सारे obese patient को CKD होगा? नहीं, कुछ रिस्क फैक्टर साथ में होने चाहिए, जैसे visceral fat obesity. अब फैट है तो किस तरह का फैट है? इपिकार्डियल फैट है, विसरल फैट है, या कि सबक्यूटेनियस फैट है? तो विसरल फैट और इपिकार्डियल फैट या जो फैट which is around the viscera, others, it is associated with increased risk of CKD in this patient. If this obesity is associated with metabolic syndrome like impaired glucose tolerance, hypertension, and dyslipidemia, these patients are likely to develop CKD. Again, there are certain conditions which are associated with obesity like pulmonary hypertension, right ventricular overload, non-alcoholic fatty liver disease, and this sleep apnea. If this patient, these obese patient have these conditions, then this patient will likely to have increased risk of renal injury. Again, low nephron numbers, nephron mass reduction, and progressive loss of functioning nephron. These all are associated with increased risk of renal injury. So we have to evaluate obese patient for all these conditions, and then we can assess that whether this patient is having increased risk of CKD or not increased risk of CKD. Now coming to the other condition which obesity can cause, like obesity increases the risk of nephrolithiasis because it facilitates the metabolic factors which increases the risk of renal stone, and it causes recurrent renal stones. And complication is that in obesity, managing renal stone is quite cumbersome because lithotripsy and all endoscopic procedures are quite cumbersome in such patients. Now, renal cancer is also increased in obese patients, and the risk of kidney cancer was increased by 35% in overweight participants and 76% in subject in proportion to normal weight participants, irrespective of the gender. Now, this is the one term fatty kidney. So, when the fat goes around the renal sinus, then these patients are having increased risk of CKD, and the pathophysiology is this, that this causes decreased macular densa sodium. Decreased macular densa in sodium causes decreased tubular feedback. This will cause afferent arterial dilatation, and it will lead to global hyperfiltration, and this will cause proteinuria and all other renal injury. Now, there is a one condition, obesity paradox, which occurs in CKD. What is this? ये कहा जाता है कि obesity CKD को prone है, obese patient CKD के लिए prone है. But once CKD is in advanced stage or CKD patient goes into dialysis, it has been seen in the studies that the patient who are slightly obese, they do better. And why? Because there is a sarcopenic obesity occurs in this CKD patient. There is protein energy malnutrition, there is a cachexia, there is a low grade inflammation in the body. So these all causes poor quality of life in advanced CKD if patient will have low body weight. So there is a U curve occurs in advanced CKD and dialysis patient. If patient is having malnutrition or underweight, they will do poor. If patient is having overweight like BMI more than 30, they will do poor. So likely in this patient, we should keep BMI under 25 to 30. Now coming to the assessment of diagnosis in CKD in obese patient. There is no clear guidelines related to the diagnosis and assessment of CKD within the people with obesity, contrary to a person with hypertension, diabetes, and CVD. Severe obesity is associated with poorer performance of standard EGFR. One example is this. You can see here, there are three persons. They have similar height and different weight. Similar height 178 centimeter, 178, 178. But weight is different. So that their body mass index will be different, 20, 40, and 60. And if you will calculate the estimated GFR by this CKD-EPI formula, then it will come around 90 for all the population. But if you will index it with body surface area, then for the first person the GFR will be 88, for the third person GFR will be 51. So it is underestimating. So if you will index the body surface, if you will index the PGFR for body surface area, then we will get the underestimation of GFR. So it is one of the problem, and the researchers are saying that at present we should not index GFR to the body surface area, but there are certain pitfalls to that also. So what to do in these conditions? So if a person with say BMI 40 or 45 will come and say that my weight is this, so how will you calculate this GFR? So there are two ways. First is whether this patient will require GFR for certain conditions like kidney donation or any body donation, or during monitoring of chemotherapy. If this is the crucial condition, and in this crucial condition, you have to rely on measured GFR, and you have to measure GFR by this inulin or 15-20 ETA or this iothalamate dye method. So these are the conditions where you have to rely on measured GFR. And in other conditions, you can combine CKD, EPI, creatine, and cystatin. And in these conditions, cystatins have played the role. So we have to measure creatine and cystatin simultaneously, and then put this in this formula, and then we can rely on this EGFR for these obese patients. Now, why to manage obesity in CKD? Because obesity increases the risk of CKD and intestinal disease. Obesity worsens glycemic control, hypertension, and albuminuria. Obesity increases cardiovascular disease and CV mortality. So there is no dedicated treatment option or treatment guidelines are available for obesity-related kidney disease, and you have to rely on expert opinion. And the treatment protocols is diet, pharmacotherapy, and metabolic surgeries. So as far as diets is concerned, there are various diets has been proposed: Mediterranean diet, low carbohydrate diet, low fat diet, very low calorie ketogenic diet. But for the diet, I have to say one thing, that they are not sustainable. They don't cause a sustainable weight loss. So you cannot rely only on the diet. So you have to tell your patient to exercise. So how much exercise? 150-minute moderate intensity exercise in a week is sufficient. But firstly, you have to check his cardiorespiratory fitness before going to these exercises. So you have to combine diet and exercise both. And as far as diet is concerned, low protein diet in the range of 0.6 to 0.8 gram per kilogram day, and the diet should be plant dominated. That means more than 50% of the plant-based source. Protein should be more than 50% plant-based source, and it is also called as PLATO diet, plant dominant low protein diet. Now coming to the drug, there are 4 classes of drugs which has been approved initially, like orlistat, phentermine, this bupropion, naltrexone, but these all have various side effects, and they cannot be used in the CKD stage 3 and above, and they have very little reduction in the weight. So with this old medicine, we have little weight with more pain. So we have to rely on the newer drugs, and these newer drugs are this semaglutide, which has shown to be wonderful drug and shown to decrease body weight in the range of 14%. And why I am saying so? There are 3 trials: one with liraglutide, one is semaglutide, one is dulaglutide, and these trials are LEADER, this SUSTAIN 6, and this REWIND, and they all have shown that this molecule is showing a decrease in composite kidney outcomes, including microalbuminuria. And KIDGO 2020 guideline also says that in patients with type 2 diabetes and CKD, who have not achieved individualized glycemic target despite use of metformin and SGLT2 inhibitor treatment, or who are unable to use those medications, we recommend a long-acting GLP-1 receptor agonist. But we don't know, there are no recommendations for non-diabetic obese CKD patient. So, but certainly this will come in near future. Another molecule is this tirzepatide, which has shown also a wonderful molecule, and this is dual antagonist, dual agonist, GLP-1 plus GRP-1. So this is dual agonist is also doing wonderful, and this will come in a big way in the treatment of obesity in CKD patients as well. Now coming to this SGLT2 inhibitor, we all know that they are causing loss of glucose in the urine, and so they are decreasing the calorie in the bodies, and they are the wonderful drugs as far as kidney is concerned, heart is concerned, and over the long-term treatment, they can cause 2 to 3 kilograms of weight loss, which can occur in the 6 months. But they can cause more weight loss if we can restrict carbohydrate. But with SGLT2, it has been seen that your carbohydrate craving is increased, so they are not causing much weight loss, which can be achieved with this molecule due to this carbohydrate craving with SGLT2 inhibitor. One interesting thing is that this ketone-based therapy for kidneys. So the researcher is saying that if you will maintain low level of ketonemia in body, like in diabetic ketoacidosis, ketone levels are very high, more than 25. But if you can maintain low level of ketonemia in the range of 2 to 3 in the body, then it can have good effect on the kidney, and it can have decreased oxidative stress, inflammation, cell death, and even kidney aging can be retarded by this. This is in the research. Research is going on this, and how can we produce these ketones? By dietary restriction, by fasting, by ketogenic diet, by physical exercise. Ketone esters are there, ketone salts are there, and of course these SGLT2 inhibitors can cause low level of ketonemia in body, and it can have good effect on the kidneys as well. Now metformin, wonderful drug. For years we are using this. So how it causes? It causes weight loss. So how it causes? It has been seen recently that metformin increases the level of growth differentiation factor 15 in the kidney and circulation to activate glial cell line derived neurotrophic factor family receptor in the area of prostamina to reduce body weight. So we have 3 molecules, this metformin, this GLP, and this SGLT2 inhibitor, which we can use in this CKD patient. Now coming to the bariatric surgery, and it has been seen that bariatric surgery improves the diabetes, improves the BP, improvements in diabetic nephropathy has also been claimed. So who qualifies for bariatric surgery? When BMI is more than 40, if BMI is 35 to 39.9, with at least one comorbid condition like type 2 diabetes, hypertension, hyperlipidemia, non-alcoholic fatty liver disease, this cardiovascular disease, this obstructive sleep apnea, and this carcinoma. And this and if patient have had non-surgical treatments. So now coming to the what are the types of bariatric surgery? Bariatric surgeries are restrictive one and diversion one, and we can achieve weight loss of around 47.5% to 70% with bariatric surgery. So what about the bariatric surgery? Bariatric surgery is extremely effective for achieving weight loss and improving CKD risk factors such as hypertension and diabetes. In observational studies, bariatric surgery is associated with improvement in creatinine-based renal outcome, although additional long-term studies are required for these bariatric studies. In any case, other risks associated with surgery are AKI and oxalate nephropathies, micronutrient deficiency, and protein malnutrition should be weighed before referring patient for surgery. So now coming to the take-home message, obesity is an independent risk factor for the development and progression of CKD. Increased waist circumference should be indication of weight loss even in normal BMI. Unfortunately, there is currently no clinical practice guideline for the management of subjects with obesity and CKD. Weight loss achieved through nutritional, pharmacological, and surgical approach can slow the progression of kidney damage and can lead to a significant reduction in proteinuria and improvement in GFR. SGLT2 inhibitor induces a metabolic shift toward ketogenesis, which is likely to account for sustained weight loss. Consider GLP-1 receptor agonists for weight loss. Adjunct can be added to SGLT2 inhibitor. Several GLP-1 receptor dual or polygonist agents are under evaluation with the potential to achieve greater weight loss than GLP-1 receptor agonist alone. Bariatric surgery is extremely effective for achieving weight loss and improving CKD risk factors such as hypertension and diabetes. Thank you very much for patience. I will be happy to take questions if any. After that, we will go with this, which is not my domain, but I will do the quiz for all of you.
Just one question. You had mentioned about 4 molecules: GLP-1, SGLT2, metformin, and semaglutide for weight loss. There's a common consensus regarding regarding metformin that it should not be used when renal impairment is there and in pregnancy. Though we